Today we will be talking about hypoplastic left heart syndrome, also known as HLHS. In this presentation, we will be looking at how normal heart formation is altered in this disorder. So, what is HLHS? HLHS is a congenital heart disease affecting the left side of the heart. In this disease, we see cardiac underdevelopment or malformation. The specific cause is not yet known, although some researchers agree that HLHS is heritable. HLHS may occur spontaneously, and therefore its heritability is thought to be complex. In the image to the left, we see what blood flow looks like in a patient with HLHS who has not undergone corrective surgery. Before we get into how an HLHS heart differs from a normal heart, we will discuss the development of a normal heart. The heart typically forms around the third week of embryonic development. As we know, during gastrulation, we form three germ layers: the endoderm, the ectoderm, and the mesoderm. All of these germ layers give rise to different structures. The mesodermal germ layer gives rise to the heart, among other structures. In this image below, we can see a cross-section of the germ layers. To orient ourselves, here we see the ectoderm, and the red structures down here show the mesoderm. The mesoderm is comprised of multiple portions: the paraxial mesoderm, the intermediate mesoderm, and the lateral plate mesoderm. It is the lateral plate of the mesoderm that gives rise to the heart. If we want to be more specific, there are two parts to the lateral plate: the somite and the splanchnic portion. The splanchnic portion is what gives rise to the cardiac structures. The cardiogenic mesoderm cells that are derived from the splanchnic lateral plate then differentiate into both the first heart field and the second heart field. The primary heart field gives rise to the left ventricle, atria, and part of the right ventricle, while the secondary heart field forms the right ventricle and outflow tract. These are characterized by genes such as NKX25 and VEGFs. VEGFs are vascular endothelial growth factors. Because HLHS is affected in the left ventricle, we can presume that the first heart field is affected in patients with HLHS. If everything goes well and there is proper cardiac cell differentiation and proliferation, then we form a heart like the one seen here. We will have correctly formed right atria, right and left atria, right and left ventricles, right and left AV valves, a correctly formed aorta, superior vena cava, and inferior vena cava. As mentioned before, HLHS occurs when the left side of the heart and the aorta are malformed. What will we see in these tissues that differ from the normal development of the heart? In an affected heart with HLHS, we will see a small or hypoplastic left ventricle, an absent or small mitral valve, and a hypoplastic aorta. In some severe cases, we will also see an atrial septal defect. In combination, all of these malformed structures cause poor perfusion to the systemic circulation, causing many complications. A patient with hypoplastic left heart syndrome will have to undergo multiple palliative surgeries during their infant life to correct these malformations. Chromosomal abnormalities have been linked to HLHS, among them Turner syndrome and Jacobson syndrome. Sporadic cases of HLHS are attributed to mutations in NKX25. What are some genes that are responsible for HLHS? Mutations in genes such as Notch1, NKX25, HAND1, and FOXC2/L1 give rise to HLHS. Let's talk about NKX25. NKX25 is one of the first transcription factors of cardiac mesoderm identified. It works through the Wnt pathway. Wnt signaling in turn regulates stem cell proliferation. Together, NKX25 and Wnt signaling aid in cardiac differentiation and proliferation. Therefore, mutations in NKX25, as seen in HLHS, affect cardiac tissue proliferation and growth. The image to the right shows cardiac defects in mouse hearts who have mutations in NKX25. Another gene mutation responsible for HLHS is Notch1. Notch 1 is thought to be the highest attributable mutation causing HLHS. The Notch signaling pathway is used by neighboring cells to communicate developmental cues as well as enable cell differentiation. In patients with HLHS, we can see mutations such as de novo mutations, splicing, frame shifts, and inherited rare variations. Notch 1 is important in the control of endothelial mesenchymal transformation, which is required during cardiac valve formation. And as we know, in HLHS patients, we see the malformation of the aortic valve and bicuspid valve. How can we treat HLHS? There are 3 general treatment options for HLHS patients. The first treatment option is a 3-stage open heart surgery performed during the first few months of an infant's life. The end result is the infant's ability to use the right ventricle to pump blood throughout the cardiac systemic circulation. To the right is an image of the heart of a patient with HLHS after undergoing all 3 of the corrective surgeries. We can start right here with the Norwood procedure, where a new aorta is created connecting to the right ventricle. Then the bidirectional Glenn shunt procedure connects the superior vena cava to the pulmonary artery. And lastly, the Fontaine procedure connects the inferior vena cava to the pulmonary artery. The second treatment option is undergoing a heart transplant. This may be the first option for some patients depending on the severity of HLHS and how compromised an infant's heart is at birth. Comfort, non-life-saving support is the last option. This is a passive approach in which the child is anesthetized, but prostaglandin therapy is withheld. Prostaglandin therapy is used to keep the ductus arteriosus open. Here we can see the ductus arteriosus in a patient with HLHS. Okay, hope you enjoyed learning about hypoplastic left heart syndrome and how genetic mutations give rise to this congenital heart disease.